Designing of clinical pharmacy services. This is the outline of what will be covered in this lecture, from logistics to finances. First, you should only design things that are needed. So is there an essential, established need for an advanced clinical pharmacy service? Of course. Drugs are one of the top causes of death, and adverse drug events and reactions are quite common, which lead to increased length of stay and mortality rates. Of the 9 steps in the business planning process, the first 2 were covered in the first module, and now steps 3, 4, and 6 will be covered. These are the 5 key components you need to evaluate in the design of a clinical service. Use this as a checklist when designing areas of your business plan. There are 4 types of clinical services. It should be clear which category your proposal falls under. The first type is a disease-specific clinical service. This is convenient because only one protocol needs to be approved and one set of patient education needs to be developed. This is a narrow spectrum service, with examples being diabetes clinic, hypertension clinic, or asthma clinic. The next option is a drug therapy specific clinic, looking at a specific medication or medication class that is usually high risk, high cost, or requires intensive monitoring. Then there is a population-specific service, which is far more elaborate and complicated than the first 2 mentioned. Population-specific services can focus on geriatrics, pediatrics, pregnancy, or an organ system like nephrology. Each disease state that would be evaluated in the clinic and not referred elsewhere may need its own guideline or protocol. The 4th type of service is a primary care service, which could be a MTM clinic, a compliance clinic, a drug consultation clinic, or a vaccination service. Pharmacists here have a broad scope of practice in regards to diseases and require many protocols and patient education materials to be developed. Many of these services are being transitioned to outpatient, as retail clinics and physician offices as well as urgent care centers have a lower overall cost compared to emergency departments, and they also do not discourage preventative care as much as emergency departments do. A big challenge for these services is marketing. Getting people who have gone to their physicians and the same A&E department to try these services from someone new. Your service needs to address how it will attract patients or clients. This will be discussed later in the course. Logistic planning. Once it is clear what type of service is decided, then we will need to know what are the processes and workflow of the staff, how and when the patient interfaces with the businesses, who provides what service at what time, what will be the exit criteria for the patients, how are patients recruited, from a class, from a physician, are they self-referred? For a lot of clinics, when the patient is stable, like hypertension clinic, they will be discharged from the service to their primary doctor. Some clinics, like anticoagulation, will keep patients as long as those patients are still taking warfarin. It needs to be clear which staff is performing which task, such as with this workflow example of a blood pressure clinic. Is it the pharmacist or the nurse or some other assistant actually checking the blood pressure? You need all of this information before you can estimate the number of staff and what kind of staff are needed. Spaces and facilities are an essential component that needs to be planned. The service can be conducted on medical rounds, via telephone, or face-to-face visits. They can be one-on-one or conducted as a group service, such as a smoking cessation class. How much time is spent per visit? Initial visits may require more time than follow-up visits. Be clear on where your service is located, how much space is needed, what is the size and layout, and what furniture and equipment do you need. Be careful when using currently existing equipment that you don't point out any inefficiencies within the department. An example would be, we will use computers in the pharmacy department for our service. That may mean the pharmacy has too many computers, reallocate pharmacy computers to another department. Don't take away the pharmacy's current resources. Otherwise, if your plan is rejected, these resources may be taken away from the pharmacy. This blueprint layout is excellent at showing the space needed, equipment needed, and patient flow for the service or clinic. Is an exam room needed? Multiple exam rooms? If it is within a specialty clinic, do they have the extra rooms available? Is presentation area needed? This is a diagram of a proposed anticoagulation service. A presentation room is drafted with a teaching area as well. Another example is an anemia program, where you need subcutaneous injections and training. An exam room may be beneficial because it contains all the essential supplies in the exam room, like alcohol swabs, a sharps container, a sink, etc. Group service. Classrooms need to be reserved. AV equipment need to be reserved if it does not come with the room. The location. Should the office be near the referring physicians? Proximity can help on visibility, allow opportunity to build collaborative relationships, and maintain communication. Special equipment. A special vertical laminar flow hood is needed for cytotoxic medications. Growth demands need to be predicted and account for when looking at staffing, spacing, and other requirements. Supplies and small items should be listed along with prices comprehensively. Personnel planning. Estimating personnel required includes the number and also the type of people needed. Do you need clerical staff to streamline non-clinical tasks? Who is going to do the scheduling? Is there a lot of paperwork to do, lettering and documenting? Is there any work responsibilities that can be given to a clerk? For an example, an anticoagulation clinic may have 3,000 patients to manage. Telephone service, calling stable patients, calling delinquent patients for blood tests can be done by a technician. They can help remind the patient to do the blood test. They can help document their intervention on the chart notes. Do you need a billing clerk for your service? Degree and licensing requirement are of course standards. However, not all licensed pharmacists with a degree can take on the job. If you are establishing a service to support a specialist's work, you may want to communicate with the specialist about what kinds of expectations they have from the pharmacist. Heart failure clinic. A pharmacist may need to have physical assessment skills to check for pitting edema or to use a stethoscope. An anemia management program pharmacist may need to have injection administration skill. Prior experience may be preferred by the specialists. Training can be done prior or on the job, depending on the acceptability of the manager and the specialist. Job description is a standard document for describing the role and duties of a particular job, and the development of preliminary job descriptions specific to the proposed service are often beneficial. Consider whether your employees need physical assessment skills, vaccination abilities, or certain language requirements. If you were to open up a counseling clinic, you would not hire someone like me who does not speak Cantonese. Competency tools are needed to ensure quality of your service and your staff. Competency tools can be internally developed or from an external party. Frequency of competency assessment should be set. For an internal competency assessment, it is usually set by management or a peer group, either self-created questions, assessment, or using some existing course. Or you can determine if certain hours of continuing education is sufficient. External assessment could include BCPS certification or disease certification, such as a certified diabetes educator or a certified asthma educator. Therapeutic knowledge is not the only requirement, as the communication skills of the pharmacist may be equally or more important based on the service provided. For how to quantify personnel needs, you first must estimate how many customers you have, the hours of the service, and so forth. Then you can calculate full-time equivalents. You may need to consider part-time employees or seasonal employees for a vaccination clinic or a pregnancy clinic during Year of the Dragon. A work schedule such as this one can make it clear what working hours, shifts, and so forth are needed. Also, who will cover the service during annual leave of key employees? Will there be cross-training with other positions to make scheduling more flexible? Generally, education or training should be completed before the service is initiated. Utilizing resident pharmacists for their cheaper salary is highly risky and raises serious questions about the quality and consistency of the service. Don't make it easy for management to find potential weaknesses in your service by hiring undertrained, unexperienced staff. It is perfectly okay to have a resident pharmacist train and gain exposure to your service, but you don't want them to be essential staff and the backbone of your program. Training for the service can come from many areas, a few listed here. Self-study can also be reflective in practice. Learn the most from every single patient and share interesting patient cases with colleagues and learn from colleagues. Legal requirements. In foreign countries, pharmacists may be able to prescribe under protocols in a special setting. Does that hold true in Hong Kong? Can pharmacists order labs? Perhaps yes in HA, but is there any credential needed? How do they apply for it? How about a community pharmacist? Can they order labs? If not, what do we need to do to make sure if a pharmacist can do that under current laws? Pharmacists can give injections in the U.S. and subcutaneous injections because pharmacy school offers this training as a standard. However, for flu injections, pharmacists need to be certified before they are allowed to give intramuscular injections. For oncology, what are the regulations on the clean room? If, let's say, I am teaching staff from CUHK and I want to establish a clinic at HA, can I access the patient information? I am not directly employed by HA. In what condition can I access confidential patient information, order labs, make suggestions, etc.? Perhaps an agreement needs to be typed up to outline the scope of practice, applying for privilege at the practice site. This would also apply for a pharmacist visiting an old age home. Patient privacy and information storage should be addressed in your proposal, as well as any large organizational internal policies and requirements. This is an example of a protocol for an agreement to meet legal and other requirements for the practice of the service. It also outlines the scope and powers of the pharmacist working in the clinic. The format and structure may easily be used and adapted to your service. Information technology. Your documentation system should have clean, clear, direct, and transparent system for documenting interventions. Documenting interventions is tedious and a time-consuming process. It is important to make sure it is as streamlined and straightforward as possible for your staff to use. Otherwise, documentation will not be done comprehensively by busy staff members. Documentation can be either written in forms for rapid documentation or, preferably, a computerized documentation system for easier documentation, information retrieval, and ability to further analyze clinical workload and productivity. When choosing which system or method of documentation you want to propose for your service, the following 10 items should be weighed in making your decision. The 4 most important are probably overall ease of use, quality of report generation, cost, and billing capability. Commercially available systems are more often user-friendly, but not always, and they often come with IT support who can maintain the system. Often, for smaller services, a commercially available system is utilized due to the large upfront cost it would take to develop one's own system. These are some of the commercially available clinical decision support systems that I have had experience with: Quantify, Theradoc, and MedMind. Nowadays, it is becoming more common for CPOE or EMR systems to have clinical decision support systems built within the computer software, so a separate system and login is not required by personnel. These systems can run reports of pre-selected information that can bring to the attention of the clinical pharmacist, including abnormal labs, duplicate therapies, and many other reports to streamline and focus the pharmacist's attention on certain patients and interventions, which can be important when time, as always, is limited. Focusing your attention can also optimize profitability and interventions for your service. These can be specifically tailored and directed for specific wards within the hospital. They can also be used to assess follow-up and acceptance or rejection rates from the physicians. Here is one case study of how implementation of a quality clinical decision support system affected the number of interventions and cost savings. The gray bars are the number of interventions and cost savings by clinical pharmacists in a hospital in San Diego before implementation of a CDSS. The red bars are after the implementation. Due to this success, the hospital hired 2 new pharmacists and new laptops for all pharmacists to use on rounds in the hospital to handle the increasing amount of interventions and help usher in all the savings. These are some of the cost savings listed by the program Quantify, that is incurred by having a pharmacist perform the clinical tasks. Some common ones include a renal dose adjustment that takes just 5 minutes and can potentially save 116 Hong Kong dollars, or a therapeutic interchange that can take 15 minutes to do and would have the same amount of cost savings. Data such as this is essential in determining the profitability of your service. Probably the most common complaint of pharmacists in regards to CDSS is that they are time-consuming. Be careful, as purchasing the system, installing the system, training personnel, and designing reports from the system can be costly and time-consuming. It is particularly useful for new graduates as it helps provide direction at what to look for when practicing clinically. The downside is that it does have more of an aim in identifying retrospective issues rather than anticipating and preventing future problems in patient care. Finance. It is one of the most important aspects of your clinical proposal, and people find this section to be the most interesting and will be most closely scrutinized by outside assessors. The first thing anyone will ask in regards to finance is who will pay for the pharmaceutical service. In the community setting, it is likely that the patient will be paying for the service. With many third-party insurances, the challenge is, do they reimburse the service that pharmacists provide? You need to learn about the rules and regulations for claims, and maybe you can just piggyback onto the services provided by physicians. Also, the willingness to pay by patients in Hong Kong is very, very low. Also, you should address how and who does the billing. Please note the difference between reimbursement and compensation. Reimbursement is payment for a specific product, like a medication, whereas compensation is more comprehensive and includes payment for a product and value from an entire service, like a prescription and education or examination. Make sure to have a system in place to provide proper documentation that is required by reimbursement parties so that it is completed satisfactorily, as if an audit could be done at any time. The financial summary is probably where most of the time looking at your proposal will be spent. There are different sources of how money can be made. You should also state your break-even point. That is, at what time or after how many patients will the service become profitable? Technically, services don't need to be profitable as long as they are improving patient lives. However, a non-profitable service is far easier to turn away and then reinvest the money in one that both improves patient lives and is profitable. Maybe not the most convincing, but probably the most common method of reimbursement for pharmacy services is the cost avoidance or cost savings strategy. Decreasing drug cost is another effective method by increasing generic use, decreasing cost or number of prescriptions per patient. Antibiotic stewardship reduces antibiotic use and reduces length of stay. Lastly, and more common for outpatient clinics than inpatient services, is direct patient care revenue, where you are paid for each visit, each lab, each immunization, medicine purchase, or other expense or service provided by the clinic. Sometimes pharmacy models may fit into more than one financial model. Developing a financial projection. Reimbursement models can follow at least one of three directions. Direct billing is where you have to directly bill the patient, insurance company, or other party. In pharmacy, most of the time, we don't use this method to generate revenue because traditionally we offer service for free. We only charge for the product. In Hong Kong, there are a small group of pharmacists who are certified for medication therapy management and are offering extensive counseling service and are able to charge patients for a fee per visit. In the United States, medication therapy management programs are very popular as pharmacists can charge Medicare, the large insurance company, for consultation fees per visit. They have a very structured claim submission process and detailed requirement of the service. Next, you have indirect billing. This is where your service's billing is attached to the physician's billing. So technically, the physician bills for services he provided and you provided. This is a more common source of revenue. Pharmacists offer clinical service in a clinic setting and bill the patient for the entire doctor's office visit. This allows the doctor to see more patients and generate more revenue because the patients are spending more time with the pharmacist and less time with the doctor. Cost savings is not really a revenue model. An example is converting a patient from IV to PO medication sooner. The service avoids the cost that would be incurred because of the high expense of IV drugs compared to their oral equivalents. Many pharmacy services are based on this type of financial model. Cost avoidance projections can include costs associated with the saving of physician time, decreasing emergency department visits, reducing length of hospital stay, improving use of formulary or preferred drugs, decreasing cost or number of prescriptions per patient, and decreasing adverse events. Sometimes pharmacy models may fit into more than one financial model. To determine revenue estimates, you multiply the annual volume of work by the cost or charge for each unit of work. If you are using a cost savings model, then you use the cost saving per unit of work instead, like 116 Hong Kong dollars for every therapeutic interchange rather than $100 for every INR lab test. The estimation of market size is needed before doing an annual volume of work estimation. Let's use an anticoagulation service as an example. If you charge patients for each blood test check, each patient will likely come back at least monthly for lab monitoring. So, if you have 3,000 patients, and if each patient comes back monthly, then your annual volume of work will be 3,000 times 12. 36,000 units of annual volume of work. Some definitions to quickly cover are gross or net revenue, which is the total amount of income you have collected prior to taking away any deductions or costs. A deduction is a discount from the cash price that may be negotiated with payers. Net revenue is the gross revenue after deductions are applied. For your proposals, all calculations and estimates should be for a period of at least 5 years. Let's quickly go over a basic and oversimplified model to enhance understanding. If your proposal is for an IV to PO antibiotics conversion program in your hospital, how would you estimate the revenue? First, we have the total number of inpatients and the percent of patients that use antibiotics. Then, what percentage of those 58 that would be eligible for the switch to PO as per information obtained from our dispensing record. Last, a physician acceptance rate of 67% gives us an annual volume of work of 5,200 patients or switches. So our cost savings would be based on this number of annual volume of work. Next, we need to find the average cost per unit of work. So, how much cheaper is PO than IV using the wholesale price, and how many doses or days of therapy can we save? With the average length of stay in our hospital being 4.7 days based on hospital data, the guideline says we can only make a switch after 24 hours of IV therapy. So let's say 2 days without the change, meaning we could change from IV to PO for 2.7 days of their hospital stay. The average cost saved for each antibiotic is $198 per day, which means for every patient we switch, we would save an average of 534 Hong Kong dollars, assuming the service was run 7 days per week and the patients were switched as soon as possible. Inputs and data used for these numbers should be accurately and appropriately referenced in order to be convincing, preferably with local data before overseas data. So, for 5,200 patients with an average saving of $534.60, that would mean an annual net cost savings of 2.78 million Hong Kong dollars. I don't know how much you make annually, but it is unlikely to be more than the 2.78 million Hong Kong dollars saved. When projecting costs for 5 years, it is important to take into account inflation. The Consumer Price Index is a tool to determine inflation factor. As an example, in Hong Kong, the cost of everything that consumers buy in April of 2017 was 1.8% higher than 12 months ago. Also, account for higher salaries, as salary inflation is generally 3 to 5% per year. If the hospital is at full capacity, which many in Hong Kong are, then no change in the volume of units would be seen for the next 5 years. However, revenue per unit would change as the antibiotics would be getting more expensive as per the inflation factor. Also, as physicians become more accustomed to the service, your success rates may also increase. The cost estimate should be also projected for the first 5 years. Determining cost can be way more complicated because there are different kinds of costs and different ways to categorize. Startup costs include renovation of facilities, purchasing of equipment, or staff training before the program. Fixed costs are expenditures that do not vary with volume of activity. Variable cost will change when activity levels change. Some cost definitions to note include direct and indirect costs, capital costs which depreciate over the life of the item meaning the cost is spread out over the life expectancy. Overhead expenses would be things like heat or water or electricity. Some costs fall into more than one category. So, what costs would be needed for our IV to PO program? Startup costs would likely include an extra computer and desk space, and ongoing costs include salary, education materials, and office supplies. The startup costs are minimal since it is a cognitive service offered within the hospital and no new areas or buildings are needed. Education would also be quite minimal as IV to PO doesn't require an expertly trained pharmacist with advanced certifications. Although I do need to spend time educating nurses and physicians in the hospital on the service. This table shows my expected expenses, including salary and benefits inflation of 3%. At the bottom, I show the summary of my expenses for the year. Office supplies and computer costs are the same from year to year as patient numbers are not expected to increase. There are many other components to consider based on which service you are proposing, whether it be space needs, travel means, increased marketing for outpatient clinics, insurance, and so forth. Here is an example of a long-term care pharmacy expense sheet. I just want to point out that an initial investment here leads to a negative outcome. Not all services are going to be profitable in the first year. Some businesses take months to be profitable, and some businesses can easily take 3 to 5 years to become profitable. As long as steady growth is shown from month to month, that can be more predictive of success. The next principle I want to cover is the accuracy of estimates and projections. Local data is obviously preferred, and more applicable regional data can be used than international or other data such as costs from commercial systems. This preferential order of information may not always be the best, but it is what people and managers in Hong Kong want to see to enhance their trust in your estimations. It is okay to use ranges when you are just estimating based on limited data available. Remember, if you are doing a drug-specific or disease-specific service, that your service is not being evaluated by experts in each therapeutic area, but more so by financially motivated individuals and management experts. So it can be important to explain income and cost estimations rather than just stating them with no clear explanation or source. Here is an example to put you in the shoes of someone who is assessing your business plan that may very well be unknowledgeable about clinical pharmacy services. Let's say Choi Ping wants to start her own airline. You guys are as familiar with airline business as much as, say, an infectious disease specialist may be with a gout clinical pharmacy service. These are some broad cost categorizations an airline may incur. These are Choi Ping's projected expenses in each of these categories. Now, are these estimations accurate or not? This shows that it is important to explain your estimation rather than just showing them, as these could very well be just a blind guess that I made. Then, if I show you how much each of these expenses take up of Cathay and Hong Kong Airlines budget, you can then see that these expense proposals are actually reasonable and are not just my best guess. Now she can explain that she plans on doing a lot more long-haul flights, so her fuel cost will be more closely resembling Cathay than Hong Kong Airlines and can explain the other expenses listed here. Break-even analysis are tools that can show at which volume of work revenue equals the costs. Without this minimum amount of work to break even, your service would likely be rejected. So it is an important value to highlight. This table provides an example for an anticoagulation clinic where supply costs per patient are $18.25 per patient. So the profit margin per patient visit needs to exceed that and provide additional income to cover the fixed costs, which I have listed here at $220,700 per year. So let's say I charge $100 to each patient. After subtracting costs specific to that patient, I have a contribution margin of $81.75. With my annual fixed cost being $220,000, I then divide that by my contribution margin per patient, and that tells me that I would need to see 2,699 patients per year, or 2.249 patients per hour, meaning I would need to spend less than 30 minutes per patient, which is feasible. Although not all services are required to be profitable, it is certainly a massive benefit if it is at least cost-saving for your organization. Increased staffing does not always mean decreased costs for the hospital. Hiring of staff pharmacists actually increases total costs of care, whereas hiring pharmacy administrators and clinical pharmacists decrease costs of care. Certain clinical pharmacy services have good evidence supporting profitability, including drug use evaluation, drug information, adverse drug reaction monitoring, or medication reconciliation, whereas clinical research and TPN management has been shown to be non-profitable. This is a summary of the finance section. You should address all of these in your proposal. Thank you for your time and attention, and this concludes the second video.